Welcome everyone to the eMedica and Medical Protection Society MSRA Masterclass for those sitting the MSRA in 2025. For those that haven't met me before, a brief introduction. My name is Muhibur Rahman. I'm a portfolio GP, which means I'm a GP with multiple roles. I've got different clinical roles and then different non-clinical roles, including being a consultant in medical education. I'm one of the authors for the prescribing safety assessment, which many of you will have done earlier on in your training. I used to be an examiner and invigilator for the GMC, for the PLAB Part 2, the OSCE examination, and I continue to be on the examiner panel for Liverpool Medical School for OSCEs. I sit on the NICE GP reference panel, which looks at and gives feedback on new NICE guidelines before they get released, if they're going to be relevant to general practice. And I've been teaching and helping support people through situational judgment tests, MSRA, GP careers, and more for coming up to 20 years now. Our team at eMedica have now trained over 80,000 delegates since we started running courses back in 2005. I'm going to start with an overview of the MSRA, and then we're going to look at some exam style questions. We'll do some clinical ones, some SJT ones, so you can get used to the format, but also so that we can kickstart your learning. And we'll talk about revision planning, how to make the most between now and your exam, how to emulate those that didn't just pass but smashed the exam and got scores well enough that they, could get their first choice job and get interviews for competitive specialties. So, how to really do well. Okay, so let's begin. So this is what we're going to do. I'm going to start with an overview and introduction to the exam. We'll look at how different specialties will use your score for 2025 entry. There's been significant changes this year. How a lot of specialties are going to use your score. Then we'll do some clinical questions, then some SJT questions. Then we'll look at how to prepare effectively for both papers if you're aiming for a really high score. I'll do a summary, and then I'll take questions after 9:15. Okay, good, let's get into it. So the first thing is that the MSRA stands for Multi-Specialty Recruitment Assessment. It's not a standalone exam. You can't just sit it like you can sit MRCP or PLAB. You apply for specialty training. If you're eligible for specialty training and your application is longlisted, only then will you be invited to book the exam. This isn't something that you can just sit for the sake of it. Okay, so it's an assessment that's used as part of the recruitment process and only for certain specialties. So you apply for training via Oriel. Round one's open right now and closes on the 21st November. Round two, the dates haven't been confirmed, but generally it opens towards the end of July, with the exam being in September. There's 2 sittings a year. However, in round two, very few specialties recruit. So it tends to only be GP, psychiatry, anesthetics, and sometimes obstetrics. Most of the other specialties like radiology, surgical training, they only have MSRA in round one. So if your application is longlisted, you'll be invited to book the exam. They haven't confirmed when, but in previous years, it was the middle of December that the invitations to book the exam came out. And you get an email asking you to log on to Pearson VUE, not Oriel, to book the exam. And in terms of the dates, again, this year, because of a change, they haven't confirmed the dates. Historically, the exam used to be the first couple of weeks of January. But as some of you might be aware, the number of people applying for specialty training has increased hugely the last couple of years. And in the last round, the round that the exam happened in September for people starting in February, they had so many people applying that they didn't allow doctors who had passed the exam in the earlier round to resit, even if their score wasn't great. If they had got a passing score, they weren't allowed to resit because they didn't have enough spaces. So they've taken account of that, and they're planning 2 sittings for round one in January, one in February, because they're expecting a huge number of applications. As a result of this, until they know exactly how many, they won't know how many dates they need in January, whether they need the February, and if so, how many dates. And that will be confirmed, they said, by the end of November. But then the invitations to actually book are due in December at some point. In terms of where to sit the exam, there's venues all over the world. Most major countries have, in big cities, availability. In the UK, there's 150 different places you can sit the MSRA. So you will sit it at a Pearson VUE test centre. In terms of the format, the assessment lasts for 2 hours and 55 minutes in total. That includes, if you like, the 5-minute gap or break between papers. So there's 2 parts. The whole thing is done on computer. The first paper is always the professional dilemma or SJT paper. That's 95 minutes. Then there's a 5-minute interval. Then you'll have the clinical problem solving paper, which is 75 minutes. Now, these 2 papers are separated and the timing is in force. What I mean by that is, let's say someone finished this paper 5 minutes early. You won't get 5 minutes extra for this paper. When this paper starts, you'll have exactly 75 minutes for it. And there are multiple equated test forms. So it doesn't matter which specialty you're applying for, the exam has got the same curriculum for all specialties that use it. But on the same day, you sit down, this person next to you, you both press start, you could have completely different questions. That's because at the point that you select start, you're randomly allocated to one of multiple different versions of the exam set for this year. They're equated, i.e., they'll all have a similar proportion of questions from the different curriculum areas and a similar proportion of medium, hard, and easy questions so that they can compare someone that sat it on the first day in the January sitting to someone that sat it on the last day in the February sitting, because you're all sitting it in round one. Okay. And the way that the scores work is that they will take people's raw scores and they normalize or standardize the score such that whatever is the mean score for each paper is equated to 250 standardized score. So I'll give you an example. Let's say that the mean score in the clinical paper this year is 78%. Someone that got 78% would get 250 in the clinical. And let's say the mean score in SJT tends to be higher. Let's say it was 82%. Someone that got 82% in the SJT would get 250 for the SJT. So they'd get 250, 250, 500. Someone that scored better than that mean would get more than 250 for each paper. Someone that scored lower would get lower than 250. Okay. So it's not just about how you do as an absolute. It's about how do you do compared to everyone else that's sitting it in this cohort for round 1 2025. Okay, so that's an overview of the exam. Let's look at now how different specialties will use your score this year. So let's find out a little bit more about who's sitting it for what. So let me launch a poll. Please select from A to J which of the specialties listed here are you planning to apply, or maybe you've already submitted an application, because the applications have been open now since 24th of October. It's okay to pick more than one. People often will pick, their main first choice, and they might pick one or two backups. So just to get an idea. So as we would expect, GP is the most popular. 2/3 of you are applying to GP at least as one of your choices, followed by psychiatry CAMS. 1/4 of you are applying for that. Then the other ones that are really popular, we've got emergency medicine, anesthetics, both about 14%, core surgical training, just under that, but similar. And then clinical radiology or nuclear medicine, again, very popular. The ones that are slightly fewer of you are applying to, neurosurgery, there's only a few numbers anyway. Community sexual and reproductive health, again, only a handful of jobs. And then ophthalmology, about 7% of you. Okay, so let me show you how each of these different specialties are going to use your score this year. And as I mentioned, there's some significant changes this year. For GP and psychiatry, and also child and adolescent mental health services, which is a joint application with psychiatry, this year 100% of your rank is based on MSRA. So there's no interview, there's no portfolio station, there's no selection center. Okay, it's just about how do you do in the MSRA. Obstetrics, for a few people, so the top 75 scorers, we don't know what the actual score needed to be in the top 75 will be, but if you're in the top 75 out of everyone that applies for obstetrics, you can get a direct offer, i.e. you can skip the interview. They'll just base it on the fact that you've got a brilliant MSRA score. For everyone else, the MSRA will be used to decide, do you get an interview or not? And then if you get an interview, it's 1/3 of your total ranking after interview, the other 2/3 being your interview and portfolio. For emergency medicine, it will decide if you get an interview, and then it carries over and is 40% of your total rank. For neurosurgery, it's 40% of the shortlisting score that's used to decide if you'll actually get an interview. The other 60% is made up of your self-assessment. Then if you get an interview, the whole shortlisting score, so remember that's predominantly self-assessment and partly MSRA, all of that in total makes up 30%. The rest is based on how you do at the actual interview. For community sexual and reproductive health, it's going to decide if you get an interview, and then it's 25%. Anesthetics, it will decide if you get an interview, and then it's 15% only. CST, it's mainly used to decide if you get an interview. Once you get an interview, it's only 10%. The rest is about your portfolio and your how you do at the interview. Big changes this year: clinical radiology and nuclear medicine. It's only being used as a shortlisting tool. it will play no part this year in your rank after you get to it. So you need a score good enough to get you an interview. Once you get that, it's all about your interview and the self-assessment's being merged as part of that. So, that'll be part of the interview process. So it's just about how you do there. But you need a great score to get that interview in the first place, but it doesn't carry over after that. Same for ophthalmology. In the past, it used to be 15%, used to carry over. Now it's to decide if you get an interview slot. Once you get that, it's about how you do an interview. Okay, so some big changes this year compared to past years as to how the MSRA is being used in some of these specialties. Okay, for all of them though, because of the level of competition, just passing the MSRA isn't enough. Nearly everyone that sits there passes. In round one, only about 10% of people fail the exam. By fail, I mean they get the lowest bands. But so most people will pass, and that means you can get a ranking, but you need to get a great ranking to get an interview. Okay, so if we look at levels of competition, it will give you an idea. If you look at the data from the last 3 years of round one, the main rounds, if you look, I've sorted these from highest to lowest based on 2024 competition ratio. So community sexual and reproductive health had the highest, 25-1. But if you look at the trend, look, from 2022, it was 15-1. You can see that's like 50% extra. Neurosurgery has gone up a little bit. Ophthalmology from 9-1 to this last year, 14.4-1. That's 50% more competitive. Radiology has doubled, 6-12. Psych gone from about 4 to nearly 10-1. More competitive than things like anesthetics, surgical training, obstetrics, emergency medicine. Emergency medicine gone from 4.5-1 to 7.6-1, i.e. about 50% more competitive. Obstetrics is doubled, about 3.5 to 7. Anesthetics, about 50% more competitive compared to 2 years ago. CST from just under 4 to just over 5. Again, about 50%. GP, it's 2.1. The year before that, though, it was 1 and a bit. It's more than doubled in 4-year span. But this latest round, 3.7-1. In round 3, the one that some offers are still coming out for GP, it was 10-1. And the nuclear medicine, they haven't published the data for 2024, but the year before that, this looks deceptive, but there were only a few jobs, and so not that many people that applied for nuclear medicine anyway. And then there was a dual CCT program for GP and public health last year introduced, which also used MSRA. That was actually the most competitive specialty out of all of them. It was 112-1. Okay, what that translates to though is that the score that you need to get an interview or to get an offer has gone up significantly. If I give you an idea, radiology, a few years ago, you could get an interview with a score in like the high 520s, maybe 530. Last year, in the initial wave, you didn't get an interview unless you scored 555, which is a very high score. CST's only been using it for a couple of years. It's 532 last year to get an interview. Ophthalmology, it's gone from just over 500 to 541. Anesthetics, 566 last year. GP has gone to, you could get a job offer with a score in the low 400s to round 1 last year was 481. In the current round, the lowest score that's got an offer is 510. So going forward in 2025, GP, there were 15,000 people applied last year for 4,000 jobs. I'm expecting it to be over 18,000 this year. So I think this next year, 500 won't be enough to get an offer in GP. I suspect that the cutoff will be, and that will be, you've been on the waiting list and you get an offer, could be your last choice. It's from what's left outside of the main window of offers. So for any specialty, I think the big thing to understand is that just because of the number of people applying, it's now really, really competitive. None of these are easy to get into. Okay. There used to be a time that people used to think that some of these specialties would be fine as a backup. They're all really, really challenging to get into. So you just need to make sure that you give it your absolute best effort, okay? Because competition is going up year on year. So let's move on to actually practice some questions, okay? Remember the clinical paper, 75 minutes, you're going to answer 97 questions. Only 86 of those carry marks, and they carry 1 mark each. The other 11 are pilot questions. They carry 0 marks. They don't look any different. You won't know which ones are pilot, but every paper has 11 questions that are there for research purposes. They're testing new questions to increase the size of their exam bank. Remember, they have multiple versions of the exam for each sitting, so they need a huge bank. All right. So you have to take all 97 seriously. And there's two main question formats: extended matching questions, which come in sets, and single best answer questions, which are on their own. And then there are some questions that, you might get the odd algorithm question where you have to drag a label into the right place to show that you know that guideline or that algorithm. And you may get a multiple best answer where it asks you which two of the following are suitable treatments, and you get a mark for each one. But these aren't common. Almost all of the questions are going to either be extended matching questions or single best answer. Now, the clinical paper has a broad curriculum. As I mentioned earlier, whether you're applying for radiology or GP or psychiatry or obstetrics, all of you, the curriculum is the same. There's not a different curriculum for people that are applying for different specialties. This is the curriculum. This is taken from the MSRA blueprint, the official document. And these 12 blocks that you can see here is how the questions are spread in the exam, i.e., in the real exam, each version of the exam will have approximately as many cardiovascular related questions as dermatology, ENT, and ophthalmology combined. All of the questions covering these specialties combined will be about as many as endocrinology metabolic, which would be about as many as pediatrics, which would be about as many as infectious disease, hematology, immunology, allergies, and genetics, all combined. So in terms of the curriculum, you can see it's huge. They're not testing, have you got membership level knowledge about one specialty? What they're testing is, do you have a broad medical knowledge across specialties as a proxy for that? Are you ready to be trained in whichever specialty you get into? So for example, if you get into radiology, the actual radiology, they're going to teach you once you're in radiology training, okay? What they're testing here is, and using as a filter to shortlist, is have you got a broad-based medical knowledge? And the level of knowledge they're testing is the knowledge expected of a doctor who's in foundation year 2. You've done finals, you've been working as a doctor for more than a year now, all right? So therefore, you will have been prescribing, you will have been actually clerking patients, you will have been managing emergencies, all right? So this is the curriculum. So let's look at, as I mentioned, there's two main types of questions: extended matching questions. Now, these come in sets of 2, 3, 4, or more. In a given set, the answer options for all of the questions will be the same, but there's a different question, and there's only one question per screen. You've got about 45 seconds per question if you want to finish the exam with a minute or two to go over any that you were unsure of. So let's go straight into it. I'll show you the first question. What I'm going to do, I'm going to actually show you all 3 questions in the set, and then we'll look at the answers, because if I explain the first one, it might give you the answers to the second one, okay? So write down your answers at home for all 3, and we'll come back. Okay, so hopefully you've written down your answers for each one. I'm going to launch the poll for one at a time now. While you select what you've already decided, I'll just remind you of the question. So key things in this question is that this patient is 55 years old and they've got stage 1 hypertension, but with risk enough that they need drug treatment, because not everyone with stage 1 needs drugs. Okay, this is important. They're not on any medication and they're otherwise well. They don't have any other diseases or illnesses that might change what's a suitable treatment for them. And then the ethnicity is white British. So what's the most suitable? So we've got a split here. Just over half of you have picked C, calcium channel blocker, and just under half, 40-something% of you, have picked A, angiotensin converting enzyme, ACE inhibitor. Okay, the correct answer is C, calcium channel blocker. Why is that? Because if we look at the guideline, this is from the NICE guideline on hypertension management, the current one. In terms of someone who needs medication, the first step when you're starting them on one drug, to decide what they go on, you need to look at 3 questions. Number 1, are they diabetic? If they're diabetic, then you're going to start them on this side of the algorithm, an A-class drug. Okay. Second question, are they of Afro-Caribbean family heritage? Okay, because if they're diabetic, remember it's an A-class drug. If they're not diabetic and they're Afro-Caribbean, then regardless of age, it's a calcium channel blocker. If they are not diabetic and they're not Afro-Caribbean, now you care about age. Under 55, it would be an A-class drug. So A-class drug is ACE inhibitor or ARB. And if they're 55 or more, and this patient was 55, then it's C, a calcium channel blocker. That's why this patient, can you see, would be started on a calcium channel blocker, because they're 55. They're not diabetic. They're not Afro-Caribbean. Okay, so calcium channel blocker is the first line drug for this patient. Okay, second one in the set. So remember, you've already decided your answer. You're just entering what you already decided. So the key thing here, this patient is Nigerian and they've got diabetes. Okay, the age is 60. That's not relevant for this particular question, but in some questions, age might be relevant, like the one before. But because they're of Afro-Caribbean heritage and they've got diabetes, this is one of the special circumstances. So big split this time. Most popular answer, most of you picked ACE inhibitor, and then about a fifth picked ARB, a fifth picked calcium channel blocker. Correct answer is ARB. And that's because this is one of the special circumstances. If someone is both diabetic and Afro-Caribbean, because in the guideline, whenever a patient who's Afro-Caribbean needs an A-class drug, the first line is ARB, not ACE inhibitor. Whereas if they were not Afro-Caribbean, ACE inhibitor would be first line, and you'd use an ARB if there was a reason that they couldn't have it or if they didn't tolerate it. Type into the chat, what's a really common side effect that leads patients who start an ACE inhibitor to stop after a few weeks? What's one of the most common ones we always warn patients about? A dry cough. Yeah, absolutely. Okay. But you see, because this patient's Afro-Caribbean and they're diabetic, then they need an A-class drug, but that A-class drug is an ARB, first line. Okay. It's one of the special circumstances. That's why it's worth knowing. That's why we're covering it. Okay. Last one in the set. Now, can you see this particular question? There are 8 options. In the MSRA, extended matching questions can sometimes have 9, 10, even 11 answer options for you to pick from. Okay. So key things here is that this patient is 41 and they're having an antenatal appointment, i.e. they're pregnant. No other medical history, not on any medication. So the most popular answer, about 60% of you picked a beta blocker, and then it's a spread between ACE inhibitor, calcium channel blocker, and alpha blocker, right? The correct answer is beta blocker. Type into the chat, just for additional learning, which one specifically would be considered first line for this patient who's pregnant. And I'm going to look at something really important in technique after that. Okay, so I look at the chat. Well done. Most of you have got it correct. The first line for someone who's pregnant, if you're starting treatment or if you're changing from something else, is labetalol. Okay, so beta blocker specifically recommended for treating hypertension in pregnancy. Now, if labetalol's not suitable, nifedipine, which is calcium channel blocker, but a specific one, is suitable. But can you see here? It's an unlicensed use. So this is why, if we go back to the question, bit of technique here, most suitable medication means most suitable for this patient in this scenario. It doesn't mean none of the others would work or none of the others can be prescribed. It means it's a relative term, right? What's the best one for you to actually give this patient in this situation? So it's a general principle of prescribing that if you have a treatment like labetalol, which is E, which is licensed for this condition, and you have one which can be used, but it's unlicensed, sometimes called off-book prescribing, like nifedipine, which is a calcium channel blocker, then the more suitable one is the one that's licensed because you've got more trial data on it. That's why E is the correct answer. You can see it because it asks most. If this question was a multiple best answer and it said, which two classes of medication could you prescribe for this patient, then the answer would be C and E because you could give nifedipine. There's also another one, and that is methyl-dopa. If labetalol and nifedipine are not suitable, then methyl-dopa, which is a centrally acting antihypertensive, can be used for hypertension in pregnancy. Okay. What's really important is that A-class drugs, ACE inhibitors, ARBs, are not safe in pregnancy. So if someone was already on an ACE inhibitor and well controlled, and then they became pregnant, you'd change them to labetalol. Similarly, thiazide-like diuretics not recommended in pregnancy as safe. All right, so you change them. Okay, so do you see, this one's licensed, nifedipine's unlicensed, so this is the better option. That's why E is the right answer and not C. Okay. Right, let's do another set of 2 extended matching questions, then we'll do some single best answers. Again, I'll show you both questions. Write down your answers at home, then I'll come back and I'll launch the poll for each one. Here we go. Great, well done, everyone. So let's launch the poll. First one, here we go. So as a reminder, this is a 70-year-old patient in a nursing home. And if you look at their symptoms that they've got, you might be thinking about a UTI, right? Dysuria, nocturia, urinary frequency, but without feeling thirsty and no blood. So, we might be thinking about a UTI. This is the key word here. The most appropriate diagnostic test for this patient. Okay. Sometimes it's really easy to miss one simple keyword and it can change the answer. So the split here, about a third of you, just under a third, picked A, urine dipstick, and over 2/3 picked B, urine culture and sensitivity. Okay, so the correct answer is B, urine culture and sensitivity. Why is urine dipstick not the right answer? Because in a patient who's 65 plus, you can't use urine dipstick as a diagnostic tool. Okay, and so it's not accurate enough. Whereas if you had a younger patient, someone in their 20s, very typical history, you suspect an uncomplicated UTI, a urine dipstick, if nitrites are there and they've got leukocytes, that would be enough for you to diagnose. You don't need to send a culture. For this patient, you need to send a culture. And a dipstick's a screening tool predominantly. But as I said, in an uncomplicated with very typical features, you can use it to make a diagnosis without bothering to send a culture. But in this group, the guidelines recommend that you always send a culture and that a dipstick is not reliable for you to make a diagnosis. Okay, do you see the key word here being diagnostic test? That's why the correct answer is B. So women under 65, no risk factors for complicated UTI, i.e. they've not got a catheter, they've not got a history of recurrent UTI, things like that. typical history, do a urine dipstick, and if nitrites are there, about 90% are going to have a UTI. That'll be enough for you to decide, okay, I'll just empirically start antibiotics. But women 65 plus, women with a catheter, with additional risk factors for complicated UTI, any one of those or more, dipstick's not reliable. You need a culture. Okay. So pregnant women, send a culture. Persistent or recurrent UTI, not resolving with treatment, 65 plus female, send a culture. Okay. Second one in the set. So this patient had multiple UTIs over a year. The key thing here is, number one, their age, 4. Number 2, that the last episode was 4 months ago, and they don't have one at the moment, it seems, because they're well in themselves. Okay. Now, this is a good example. The clinical paper is, I would say, 90% knowledge, 10% technique. Whereas the SJT is the other way. It's like 90% technique and 10% knowledge, right? A big part of doing well in the clinical paper is covering the topics, doing enough questions, reading enough guidelines, that you learn the material, you learn the subject, which is broad, so it takes time, right? But there is technique, reading and picking up on keywords, managing your time, things like that, okay? So correct answer is E, DMSA scan. And just over half of you got that right. A lot of you had picked abdominal ultrasound. That was the second most popular answer. And then quite a few of you had picked KUB X-ray, okay? Again, what does most appropriate mean as a keyword? Appropriate for this patient. They're only 4 years old. In this situation, multiple UTIs, but well now, last episode 4 months ago. So if we look at what the guideline says about that, DMSA, by the way, stands for dimercaptosuccinic acid. No one can remember that. That's why we just called it DMSA. So children 3 plus, do you see why that age is important? Okay, they've got an atypical UTI, they'd have an ultrasound during the acute infection. And then if they've got a recurrent UTI, they'll generally have an ultrasound within 6 weeks of the episode finishing, and then a DMSA scan to look for long-term features, like is there scarring and things like that, and what's going on 4 to 6 months after the acute infection. So if you go back, you can see 4 months ago, if they needed an ultrasound, that would have been ordered beforehand, because you have that within 6 weeks. And so they would have already had that. PEDS would have arranged that. At this point, they need a DMSA scan, right? So that's why that's the correct answer. Okay, single best answers have a scenario. They always have a title, and then there's just one right answer. There could be anywhere from 5, which is the fewest, up to 7, 8 options for a single best answer. So while you select your answer, just a quick reminder, the bit of technique in this question is this is what we call a negatively framed question. Now, the majority of questions in the MSRA are positively framed. It will ask you, what is an appropriate treatment? How would you treat this patient? What test would you do? What is the likely diagnosis? You can get some questions which are negatively framed, and it's easy to miss if you're not reading carefully. So you've got this patient terminally ill, metastatic cancer. The symptom they've got is severe nausea and vomiting. And the nurse suggests, maybe a syringe driver might help, because you can put different things in there, including things to help with the nausea and vomiting. But look what the question's asking. It's not asking what would help. It's asking which of the following would be least helpful in alleviating the symptoms of severe nausea and vomiting. I.e., what would you not give this patient for this particular indication, rather than what would you give? Now, if you miss this negative word, you might be in a rush and you're just reading this and you think, oh yeah, syringe driver, yeah, I had a patient like this and they were really vomiting badly, and we gave them some dexamethasone and it really helped. And we do use that sometimes. Before I was a GP, I worked in palliative care. And dexamethasone can be helpful in some patients, or cyclazine can be, or haloperidol can be, or levomepromazine can be mixed in with things like diamorphine. So you've got something for pain relief, something to help with their nausea and vomiting. So the correct answer is B. Hyoscine hydrobromide can be used in a palliative care setting, but it's used to clear respiratory secretions or to help with bowel colic, not for nausea and vomiting. So do you see, all of the others may be of some help, depending on the specifics. For example, it says metastatic. When might dexamethasone be particularly useful? If someone had Mets where? Think about a cause in that kind of context of severe vomiting. Yeah, someone with brain mets, okay? It can be really helpful in that situation, okay? But hyoscine hydrobromide, it can be used, but it's used for these things, not for severe nausea and vomiting. So do you see, this would be the least helpful in alleviating his symptoms, not just least helpful, full stop, but in the symptoms that he's got. And if you miss that it was negatively framed, it's easy to have the knowledge and still lose a mark. Do you see? So reading carefully, understanding and picking up keywords is part of the technique. Okay, let's look at the last one. Here we go, 45 seconds. Okay, great. So Lyme disease, type into the chat, what's a first-line treatment for Lyme disease? It's in the question. Doxycycline, right? So first line, they've been given this doxycycline, and then less than a day later, they come back with these symptoms: fever, facial flushing, bit tachycardic, blood pressure is a little bit low. So what's the likely cause of the symptoms? The correct answer is D, the Jarisch-Herxheimer reaction. It's quite specific side effect that's quite common when we give someone doxycycline for Lyme disease. Common enough that it's recommended that you warn the patient that, look, this could happen. About 15% of patients that you start antibiotics for Lyme disease, they get this specific side effect. And if you don't warn them about it, that this is actually a reaction that's known, keep going with the medication, what do you think might happen? Patients start taking the medication, they start getting these things which make them uncomfortable, they stop taking it. Then, of course, the risk is that their Lyme disease isn't treated and they become more unwell. So that's why it's specifically mentioned to talk about this, right? So the Jarisch-Herxheimer reaction can actually happen with any antibiotic treatment, but it's really common when you give doxycycline for patients with Lyme disease, okay? If you look in the BNF, things that are seen in more than 10% of patients are described as very common side effects. Okay, so it's very common, right? Usually will occur within the first 24 hours of treatment. And actually it's because it's working. It's starting to work, it's killing the bacteria, and the bacteria, when it dies, releases toxins, and that reacts with the antibiotics and causes this reaction. So you find that their fever gets worse, their muscle pains, headache, and then they might be tachycardic, hyperventilating, they get flushed, blood pressure drops, but only a little bit. So can you think of other infections where this is commonly seen? This is probably the one where it's very, very common, but there's at least one more where it's common enough that we'd warn patients about it. And then another one where you might see it as well. Type into the chat. Yeah, well done. So syphilis is the one where we always warn them because it's common, and leptospirosis. But syphilis, very, very another important cause of this reaction. Okay, this, by the way, is one of the 112 case cards in our clinical case cards, which are available as sort of printed or as a digital edition, as a quick way to revise topics and guidelines. So in terms of how to prepare, you know, you want to do a mixture of active learning by doing things like practicing questions, and passive learning, like doing things like reading. and you want to consolidate your knowledge, then you want to make sure, can I actually answer a question rather than just, recall the facts? Can I apply it to a clinical case or a scenario, how it might be given in a question, sometimes with very little information. Some of the questions are very short. Some of them, there's a bit more information. And can I do it to time? As you saw, 45 seconds isn't very long to look at it, think about it, and decide. You want to allow enough time that you can cover the curriculum systematically. Practice realistic questions. We also want to work on exam technique. So when you're reading the questions, you know what words to watch out for, and you can understand what is the examiner actually testing. And to work on your time management, do some full-timed mocks that will help you build up your sort of stamina of answering so many questions, one after the other, from different subjects thrown at you, but also managing your time so you don't rush too much and make mistakes, but you don't sort of take so long on different questions that you don't see the last 10 questions, because that could have a big impact on your marks. Now, the questions in the clinical paper, they will relate to one or more of these question types. So some will be about relevant investigations. So we looked at, for example, MSU, urine dipstick, KUB, and so on. Some will be about making a diagnosis. Now, you can see some of these, they're two-step questions. So we have to make a diagnosis to work out what might be an appropriate thing to do for it. Some will be about emergency care, the kind of emergencies a junior doctor should be able to deal with. So acute severe asthma, sudden collapse, someone that goes into cardiac arrest, anaphylaxis, okay, acute coronary syndrome, these kinds of things. Some will be specifically about prescribing, like we looked at different types of medication to prescribe for different patients with hypertension, for example. And some will be about management that's not prescribing. So knowing who to admit, who to refer urgently, who to refer non-urgently, who to sort of manage in A&E or manage in GP. And in terms of the reading side of things, the Oxford Handbook of Clinical Specialties and the Oxford Handbook of Clinical Medicine, between them, they give wide coverage of all the different topics, if you like, the different curriculum areas that I showed you earlier that are covered in the exam, at enough of a level to do well in this exam, but not enough for you to do well in membership. But you're not doing membership, you see. The thing is, these are big books. And even though, like, this is the current edition of this is several years old now, several guidelines are already out of date because they've moved on since these books were published. It's the nature sometimes of publishing books that are really big like this, that often they can only renew it every 4 or 5 years. And guidelines will sometimes go out of date. So if there's a specific guideline that you want to look up, go to the source, the actual NICE website, and look up the original NICE guideline. You can search by topic and search by condition. And that's a good way. I try to incorporate that. Like if I see a patient and I want to make sure, check the guideline, or do some reading as you go, make a list of all the different topics or cases or things that you saw, let's say you're working in A&E, and then read up about them. And then practice some questions alongside that. Now, that's fine if there's a specific topic you want to look up. It's not practical to read all the NICE guidelines. There's so many of them, and each guideline can sometimes be 10, 15 pages. If you want to efficiently and quickly cover lots of guidelines quickly, then our clinical case cards were designed exactly for that, to be able to cover NICE guidelines efficiently, and they're mapped to the same things that your questions are mapped to. So here's some examples. Okay, where relevant, we've sourced and licensed high quality images. So this is an example of non-bullous impetigo, and this is the current guidelines for management. For example, in the latest guidelines, if it's low risk and localized, we use hydrogen peroxide first line rather than topical fusidic acid. Okay, the current set were updated partway through 2024, and then there's a digital edition available for those of you, because we only post this within the UK. For those outside the UK, you can access the digital edition here. And then alongside that, the mainstay of your learning for the MSRA should be practicing questions. Okay. Now, when we first started running courses and when they first introduced this exam, there weren't any question banks. And we developed the very first one because people were desperate to have some practice questions. We only had 200 questions when we started. And then it expanded and expanded. Then they changed the format, so we updated. Then they changed the format again, so we updated it again. Because initially there weren't SJT questions, and they added those later. Then they changed the format, the number of questions in each paper, the timings. So we updated all our mocks. And each year we recruit people that have done really well, so they know the format, to write original questions so that we can expand and update the material to keep it relevant and to the current format. So there's questions mapped to the curriculum areas. There's 3 full clinical mocks. There's mini mocks for clinical. There's full SJT mock. It's over 2,000 clinical questions, over 200 SJT questions. It's going to take you about 100 hours of learning to go through it once. By the way, as long as your subscription is active, you can repeat the questions as many times as you want. So you can subscribe to that anywhere from £49 for a month to 12 months is £129. So if you want to cover to the end of February, because we don't know when the exam will be, if it goes through into February as well, 4 months will cover you. 12 months would cover you to the round 2 exam as well, the September exam. So you can see like the clinical is mapped to the curriculum areas that we talked about earlier. This isn't all of them, it goes down further. And then there's also section for the SJTs, as we mentioned. There's a study guide which you can download. And then there's mini mocks and mocks. So there's a clinical question, SJT, clinical mocks. So the clinical, they're mapped. And for example, let's say you're doing a PEDS question. Okay. You can see there's a title, there's a question. Sometimes they're very short, like in the exam, you have some very short questions, some long ones. When you select your answer, you can read then, did you get it right or did you wrong? There's a concise explanation, so you can do your learning as you go. The extended matching questions, just like in the exam, you can see 1 of 3. There's only 1 question here. When you answer that and read the explanation and go to the next one, 2 of 3 will have the same answer options, but a different question. Only 1 question per screen. That's how it is in the exam. We haven't put all of them, 1, 2, and 3 of 3 on the same page, which makes it easier than the real exam. Then there's mini mocks. So you can do those timed, or if you get extra time, because you've got dyslexia or neurodiversity in some other form, you can do an extra time. So you get used to the actual timing for your exam. And then there's 3 full clinical mocks. And then there's a whole SJT section, which I'll show you later when we get to SJT. Okay. And one of the feedbacks that we get a lot from people that have used multiple banks and scored well is that they found this very similar to the real exam in terms of layout, question style, the fact that our EMQs are 1 question per screen, and the fact that it's categorized by topic and mapped to the curriculum. A lot of people find that helpful to do one subject at a time. Okay. So you can see examples of people that have scored well, that have used multiple banks, and they found this to be similar. This doctor got into anesthetics, again, did different ones, but they liked that they could do it by topic to structure their revision. Got a fantastic score. Okay. Again, someone saying it's the closest to the MSRA compared to others. They'd use multiple banks. They've got 632. They've got offers for both anesthetics and GP. Okay. So let's move on to the SJT, the professional dilemma paper. My colleagues will share the link where you can get access to the question bank if you want to subscribe on our website. You can also see it just on the main homepage. All the things that we do for MSRA are here. Okay. So the question bank's there. So the SJT, remember, is 95 minutes. And on the day of the exam, you'll do this one first. In 95 minutes, you're going to answer 50 questions. Only 42 carry marks. The other 8 carry 0 marks. They look exactly the same. You don't know which ones carry marks, which ones don't. So you have to take them all seriously. I've put in capitals here, timing, and that's because both papers are tight for time. But the SJT, a lot of people particularly find challenging for time because the questions are a lot longer. Now, there's 2 sections in the SJT. About half the questions are section 1, which are ranking questions, where you rank things from best to worst. And about half are selection questions, where you pick 3 options that go together to deal with the scenario. So the approach, the mindset, and how they're marked is completely different. That's one of the really important things to understand. So what the SJT tests is decision-making and judgment based on work-based or work-related scenarios. So they might present to you a kind of scenario that you might find when you're working in a hospital job or in a GP job. And there might be a professional, ethical dilemma or difficult situation. And what they're testing is, do you show positives or negatives for 3 core competencies: empathy and sensitivity, professional integrity, and coping with pressure. Now, each of these is broken down into lots of subdomains. Specific subdomains will be tested in specific questions. Then some questions will also test, do you have a good working knowledge of core GMC guidance and ethical guidance, and can you apply those to work-related scenarios? Okay. So let me show you what they look like, and then we'll explain how it's marked for section 1 and then section 2, because they're marked very differently too. So section 1, you'll get a scenario, and there will either be 5 or there will be 4 in some questions options. And what you're doing is you're ranking them from best to worst. So 1 is the best or most effective option. 5 is the worst or least effective option if there's 5 options. If there's only 4 options, then 4 is the worst or least effective option. You've got about a minute 53 per scenario. I'm going to give you about a minute 50 to look at this one. Then I'll ask you what you think the best order is. Okay, so have a look at this first one. Here we go. Okay, time's up. Please write down your order into the chat. Okay. So write down, while you're doing that, I'll just do a quick read through. And while you're reading through in the exam, try to picture the scene. With the SJTs, you don't have time to come back to any questions. You want to finish the last question just a few seconds before the buzzer sounds, right? Because if you come back to one of these, you end up having to read the whole thing again. So it just wastes a lot of time, right? So just picture the scene. You're finishing a busy night shift and you're exhausted. The morning doctor's called in sick. And as you're about to leave, the senior nurse says, look, there's a message from medical staffing. Would you stay on until the early afternoon when a locum will be available? Now, this last bit is really important. You know, there's being tired, then there's being exhausted, then there's being so exhausted that you're barely able to keep your eyes open and you're unable to concentrate. Let me ask you a question before we look at the actual scenario. Is the doctor in this situation safe to be seeing patients, to be on the ward, to be making decisions, to be writing drugs, to be clerking? No. To be doing procedures, potentially. Okay. No. Okay, good. And then if we look at the options, let's look at the preferred response. And let me just have a quick look at what people have put down. So some people have put D first, some people have put A first. And then those that have started with D, some have got DA, some have got DE, and then a variety of choices for where they put B and C and so on. Okay, so there's a big range of different answers, right? Just out of interest, let me do something. I'm just going to launch a poll. Just put which letter did you put first in the poll? That's all. I only want you to put, so out of A, B, C, D, E, which one did you put at number 1? That's the only thing I'm looking at. Okay, so very interesting. So that's enough to get an idea. More than half of you put D first, about a third of you put A first, and most of the rest put E first. Okay, so there's even just between what you put number 1, there's a big spread. Okay, the preferred response is D, A, E, B, C. Okay, D, A, E, B, C. Now I'm going to come back to this and explain why, but first let me explain how it's marked. Section 1 is marked in a really complex way. It needs to be marked by a computer. It's called keyed responses marking. So where there are 5 options, like this one, there's 20 marks maximum per question. Only D, A, E, B, C. This is the only order that will give you 20. Okay. But it's not as simple as you get 4 marks for each bit that you get. Because let's say you had 3 right and 2 wrong. How many marks would you think you'd get out of 20? You might think, oh, 3 right and 2 wrong, I should get 60% of the marks. The answer is it depends. Depends which ones you've got right and which ones you've got wrong and where you've put them specifically. You could get 18 out of 20. You could get 16. You could get 14. You could get less. Okay. Every possible order has a number of marks keyed to it. So, for example, D, A, E, B, C has a number of marks put to it. If you had A and D the wrong way round, i.e., they're both near the top, but you just had them the wrong way round, but everything else was in the right place. Overall, that's really quite sensible. You'd actually get 90% of the marks for them. Whereas, can you see, if you had D at the bottom and C at the top, even though you've got 3 right and 2 wrong, you would get very few marks for that because overall it suggests poor judgment. It shows negatives. All right. So every single combination has a number of marks keyed to it. Okay. That's why it's called keyed response marking. Even if you don't get it right, as long as you have put everything into a rank, the lowest you're going to get is 8 out of 20. The most you're going to get is 18. If it's wrong, if it's right, you get 20. So only one option will ever be the best answer. But there's lots of ways that you can get most of the marks. Let me show you how you'd actually do it. And when we were trying to recreate what the real exam looks like for this, there isn't any commercial quiz software that can mark section 1 correctly. So we had to invent it. We actually hired a coder. We explained exactly how it is. And then we had to work with them until we made it work. Okay. So look, here's an example. Here's an example with 4, because some will have 4, some will have 5. The scenario will be there. You'll have 1, 2, 3, 4, or 1, 2, 3, 4, 5. Let me show you an example with 5. Okay. Okay, 1, 2, 3, 4, 5. You'll have your options A, B, C, D here, and you will, in the exam, you will drag them. So if you think this is first, you'll drag this here. If you think this is second, you'll drag this here. If you think this is third, you'll drag this here, and so on. Okay. And then it'll be marked. Okay, so like that's got 12 out of 20. Whereas if I had a different order, I could mark that and it might give me 14 or 16 or 18. Okay. Now, if I go back to the poll, as I mentioned, there was a 3-way split between A, D, and E. Those of you that had A first, that was actually a big number. A third of you had A first. Why did you put A number 1 rather than D? Just type into the chat. And then I'll explain the order so that we understand why this is the best response. And then we'll move on to a section 2 question. So just type into the chat. Anybody that put A number 1, why did you put A number 1? Okay, great. So a few people have said something along the lines of that, it's going to take time to do this. That's why they thought so. Let me try and summarize some of the different things. Because other people have said, this is dealing with it directly because they're the ones that asked you to do this. So let me know in the chat how many of you put A number 1 and D number 2, because in your mind you were thinking, this is the order in time I would do this. Like they've asked me a question, let me just contact them and say, look, I'm not going to do it. So they know they can start looking for someone else. Okay. And then I'll contact my consultant. Maybe they're not free. When they are free, I'll discuss it, discussing the whole situation, explaining everything and why it's not safe. And they've asked me and I'm tired and I'm exhausted. And that's all going to take time. Is there anyone that's why you put A1 and D2, that you were thinking, I'd do this first and then I would do this next? You were thinking about a sequence in time. Yes, lots of people are saying that's exactly what they're doing. See, this is the most common reason to lose marks in section 1 of the SJT, is if you're thinking I would do this and then I would do this as a sequence of time, you're approaching in completely the wrong way. And in a lot of questions, it would lead to you losing marks and then wondering, I don't understand why what I'm suggested is sensible. You have to look at all of these as discrete options, i.e. the key word is or, not then. Look, what they're asking you to do is, if you could only do one of these and this is your whole response and you're not going to do anything else, which is the best response? Is it this, or this, or this, or this, or this? It's not that I'm going to do all of these and this is the order I'm going to do them. I'll do this first and then I do this, and then that's not what they're asking you to do at all. If you think about it like that, unfortunately, in a lot of questions, you're going to lose marks. Okay. So the key word is or. Each of these is a separate option, and you have to imagine that is all you're doing, and that is your full response to the scenario, which is the best one. So that's why, okay, bear in mind that scenario, okay? Why is D the best response? Because can you see that in D, not only are you not doing it, you are recognizing that, look, medical staffing know that if you've worked a night shift, that they shouldn't be asking you in the first place to keep working. Why not? What's the problem with continuing to work? Let's say you weren't even so exhausted that you can't concentrate. So like this is clearly unsafe. But even if you weren't, why shouldn't you keep working for several hours, look, until the early afternoon? And it's the morning now. Handover might be 8, 9 o'clock. Early afternoon might be 2, 3. Why should you not keep working 4 or 5 hours after you've just done a night shift? Because you're going to work more than you're legally allowed to work. There's increased risk of errors, okay? There's reasons why there's legal protections, right? Fatigue can lead, and there's evidence on this. There's a study that showed that a doctor who hadn't had enough sleep, the sort of change in decision-making was similar to someone who was drunk at a couple of times over the legal limit to drive, okay? So it would be unsafe, right? So you see, look, in D, if you're discussing the whole situation, look, I'm exhausted, it's not safe, but they're asking me to do this. What this shows is, this shows positives for not just that you know your limits, but you recognize that one of your roles is that if you see something happening that could put patients and staff at risk, you might not be able to directly change it. Like you can say to them, no, they shouldn't ask you in the first place. But now your consultant, if they know about that, they could contact medical staffing and say, you shouldn't ask the residents, you shouldn't ask the doctors to stay on beyond the legal hours. This not only shows that you know your limits, you recognize it's important to be safe, but on beyond that, you're raising concerns with someone senior, which is one of the subdomains actually, okay, in knowing your limits. And so hopefully you're preventing it happening in future. But can you see, it also means who's ultimately responsible for the patients on the ward? The consultant. They know, if you told them the whole situation, then they know that the morning on call hasn't come in. They found a locum for the afternoon. I'm too tired to do now. Now they can say, okay, I'll get the registrar to cover the on call until they come. I'll hold down the fort in the clinic. You go and sleep. Okay. So this is like, if this is all you're going to do, this is the most complete answer, right? Then you've got A, right? If you say, look, I'm not going to do it, again, you're recognizing your limits, right? Whereas sometimes what people do is, if you don't look at and understand that you're comparing, it's not about good and bad. Sometimes they'll all be bad. Sometimes they'll all be good. You're comparing, is this better or worse than this? It's worse than this because while in both of these, you're not doing it, so you're not putting yourself in an unsafe situation and patients in an unsafe situation. This one, you're also raising concerns with someone senior, which you're not doing in this one, because that's your whole answer, right? Whereas, can you see, all of these ones shows you don't know your limits and they introduce risk. Okay, now this is a tough question. Now, in a particularly tough question, because generally I recommend you start at the top and you work your way down. But if you're finding it particularly tough, if you work out the top two, then work out the worst two, the middle will find itself. So let's do that, okay? If you look at B and C, in both B and C, you'd get a negative for knowing your limits, which is one of the subdomains of coping with pressure, is knowing your limits, okay? Because can you see, in both of these, you can't concentrate, you're exhausted, can't even keep your eyes open, yet you're staying on and covering the on-call, and so you're putting yourself, your patients, and your colleagues at risk. So why is, both of these are awful. Why is B not quite as awful as C? That's the question. You see, in both of these, you're being really unsafe. You're not recognizing your limits. The difference is in B, your motivation is not for yourself. You know, you're not recognizing your limits, but your motivation isn't to try to make personal gain. If you look at C, what you're saying is, look, I'll do a few hours, but I want you to give me a full day back. You're trying to take advantage. Now, what does the GMC say about this? That, look, let's say they asked you, could you do, like, we need cover on this day where someone else was supposed to do on call, but they've gone on a course and it's in 2 weeks' time and it's the weekend. It's perfectly reasonable for you to say, I'd like either, extra time off, or I'd like locum rates because it's planned. But actually, GMC guidance says that in an emergency situation, if you are helping your colleagues, you shouldn't try to make personal gain. You shouldn't try to take advantage. See, in C, you're trying to take advantage of the situation. And it's a good example of the difference between what might happen in real life and what the exam is asking you to pick according to the guidance, where relevant, what's the optimum situation. Because in real life, you're tired, you don't want to do it. You know what, you might ask for locum rate, but in an emergency, you shouldn't try to take advantage. Look, I'm going to do a few hours, but I want you to give me 8 hours back. You're trying to take advantage. Okay, that's why C is worse than B. They're both awful though, because both of them show that you don't know your limits. Now that brings me to E, because a lot of you might have thought E is great. Some of you put it first. What's the risk with E that is really subtle? This is why you have to read it carefully. You might miss this if you're not paying attention. Look, I'm too tired to work now. I'll come back in the early evening before my night shift to help out. Well, look, in the early evening, they don't need you. There's going to be a locum in the early afternoon, so they'll already have cover. On top of that, what happens if you come in a few hours early in the early evening before your night shift? What happens? What's the risk? Well done. The risk is that towards the end of your night shift, you're now overtired, you've worked more than you're legally allowed to, your concentration is likely to wane, and you might put patients at risk at that end. It's not as bad as this, because who knows, that night shift might not be as busy. You know right now you can't even keep your eyes open. You're that exhausted. So here there's definite risk. Here there's potential risk. Okay? That's why this isn't as good as these where you recognize your limits, because you're still not recognizing your limits here. Just here, it's worse. So do you see, it's about better or worse, not about good and bad in section 1. All right. And it's or. If this is my whole answer, this is the best response. Is it this or this? Not I do this and then this. It's not a sequence of time. That's really, really important to understand. Okay. You're comparing it to the one above and the one below. Okay. So section 2, you get a scenario just like section 1, but it takes longer to read. Why? There won't be 4 or 5 options. There will be 8 options in every section 2 question. So there's a lot of options just to read. And here you're asked to pick 3 options that taken together make the most appropriate combined response. Big difference. It's not or, it's and in section 2. Let's have a look. Here we go. Okay, time's up. I've launched a poll for this one because for section 2, you don't rank anything. You're not ranking 1, 2, and 3. You just tick the ones that you want. So if I show you how it is in the actual exam. So in the actual exam for section 2 questions, there'll always be 8 options, and you just tick the ones you want. Okay, so that's it. It's like that. That's how it is in the exam, right? So if I stop that, so I can see that the popular options are B, D, E, G, and H, with very few people picking F, C, or A. The others, there's quite a few. Okay, so let's do a quick read through. So you're treating this patient who's diabetic. He's unwell enough that after having the fall at home, he had to be admitted and kept in hospital. You can see a lot of people have a fall, they might be seen in A&E, rule out a fracture, sent home, right? But you see, if they've been admitted to the care of the elderly ward after this fall, they must be unwell enough that it was felt that they needed to stay in hospital. They were admitted. And you notice there's a spike that's unexplained of their sugars every evening. You can see each evening, not one off, before dinner served. And he's talked about his sweet tooth, and you've seen that his wife, who comes in the afternoon to visit, she brings him some sweets. Okay, so that's the scenario. The preferred response is B, G, and H. Okay, B, G, and H. Now, loads of you had H, quite a few of you had G, not that many had B. Okay, a lot of you either had D or E as your third option. Now, the way these are marked, very straightforward. 4 marks for each one that you get right. So if you get all 3 right, you get 12. You get any 2 right, you get 8. Any 1 right, you get 4. There's no negative marking, okay? And remember, it's the most appropriate combined response. So you've got to ask yourself, does it make sense when I read them back together, okay? Because if it doesn't, then you probably know that you haven't got full marks. So one of the things about section 2, remember section 1 is not about good and bad, it's better or worse. Section 2, there are some options that there's something negative about it. Shows a clear negative for one of those domains, empathy and sensitivity, professional integrity, coping with pressure, or it clearly goes against some GMC guidance. So you could eliminate that, and that makes your decision easier. You're picking 3 from maybe 6 because a couple of them, there's something clearly wrong with it. So there's something clearly wrong with some of the options here. Let's look at the ones we can eliminate. What's wrong with A? Why can A not be part of the right answer? What's clearly negative about it? The word confront. It shows a clear negative for empathy and sensitivity. Okay. How do you think the patient would feel? He's unwell enough that he needs to be in hospital right at the moment. By definition, that makes him quite vulnerable. And you're confronting him about someone else's behavior. He might have no control over his wife and her behavior. And so this is a very inappropriate way to approach the situation. It shows a clear negative for one of the domains. And so it's clearly out. So A's out. Okay. What's wrong with C? Well, think about one of the things in good medical practice is good clinical care. You want to put the patient's best interests at heart. If there's an unexplained spike each evening, that suggests it's regular. You can see each evening. Every word is important in the SJT. If you measure it less frequently, it might get worse and it might take you longer to pick it up. So this potentially puts the patient at risk. Okay, I'll come back to D&E because loads of you picked D&E. What's the issue with F? Why is F not part of the right answer? Hardly anyone picked F anyway. So one of the subdomains is about knowing your role in the team, and it's just not your job to decide who can visit how often. Whose job is that? The ward manager decides that. Sometimes, if it was having an impact on clinical care, the consultant might make a decision about that, but that's not recognizing your limits. As an F2, and remember, in every one of these scenarios in the exam, it doesn't matter what level you are now, you have to imagine you're an F2, all right? It's just way beyond the responsibility of an F2 to make a decision like this. But beyond that, think about the patient's psychological well-being. They might really value seeing a family member, a loved one, every day when they're unwell in hospital. You to say, oh, only come in twice a week, you might be thinking about that for clinical care, but how might that impact their psychological well-being? Do you see? That's why F's out. Now, D&E. What's the issue with D&E? It's the same issue that's with D, that's an issue with E. In both D and E, there are inappropriate breaches in confidentiality. And this is where knowing the GMC guidance, so you know when you can and can't breach confidentiality, when it might be appropriate, in which situations can you share information, without consent would help. You see, if his wife is already visiting and you discuss the recent results, there's no option here where you've combined it with where you've got his consent to share those results. That's a breach in confidentiality. Just because it's his wife doesn't give an automatic right to know his blood results. Similarly, if you discuss the results with his wife, there's no option here where you've asked his permission. That takes away from his right to say, no, I don't want my wife to know. Someone has capacity, they have the right to make that decision, right? Okay. And so this one, actually, these three are the only three that are left. Now, how do you know you've got it right? Read them back together. It doesn't have to be in alphabetical order, but ask yourself, if I add in the word and, does it make sense? And number two, together, do they address the scenario? So this is the scenario. Does this make sense? Try and picture it. It really helps. Okay. I'll do this one first. Discuss the recent blood sugar levels with Mr. Jackson and explores that. So, Mr. Jackson, I've been noticing this trend that each evening your sugars are really high. I'm not really quite sure why. But what might be helpful is for us to find out a bit more about your diet. Just talk me through yesterday. What do you have for breakfast? What about lunch? What about dinner? Did you have any snacks? Okay. And, well, look, if you have been having some things that are sweet and you've got a sweet tooth and, your sugars aren't controlled at the moment, suggest some sugar. Here's some treats that you could have that might give you the taste, but they've actually not got sugar, so they shouldn't impact your sugars in the same way. And continue to monitor their blood sugar levels at least daily. Because you must, if it's each evening, you must at the moment be doing it at least daily. So at least as frequently as you've been doing, continue to monitor. Does that make sense together? Yes. Does it resolve the situation and show positives for those domains? Yes. That's how you know you've got it right. In section 2, you can know you've got full marks before you move to the next question by doing that simple test. Read it back together. Does it make sense? Does it address the situation? Okay. So B, G, and H. So, how to prepare for the SJT. As I mentioned, the SJT is really a lot more technique than knowledge. If you understand what are the subdomains within each of these three domains, then you can spot when you're reading a question, I can see this is clearly testing this as the primary domain. This option shows negatives for empathy. This one shows positives for that, so it's going to be ranked high. This one shows a lack of professional integrity, so it's definitely not going to be part of the answer in section 2. This one shows not knowing my limits, which is one of the subdomains of coping with pressure, or doesn't show raising concerns with someone senior, which is, again, part of knowing your role. So knowing the subdomains and knowing how to spot which domains are being tested in different questions, a big part of being able to answer them appropriately. Having a good working knowledge of good medical practice and the core GMC ethical guidance, so that where it's relevant, like in this question where there was issues around confidentiality, you know how to apply it. Understanding the difference between section 1 and section 2, how to approach it, then practicing questions to time. So some of the ethical guidances that you want to know, the biomedical ethical principles: autonomy, beneficence, non-maleficence, justice, confidentiality, when you can and can't breach it, capacity, advanced refusals, do not attempt resuscitation orders, Gillick competence, the Fraser guidelines, consent, the Bolam case, the Montgomery case that changed that, the new GMC updates, the GMC 2024 updates to good medical practice, personal beliefs and medical practice for the doctor and for the patient, financial issues, when you can and can't accept gifts, for example, raising concerns, safeguarding, child and adult safeguarding. Okay, so now you can read some of these things yourself. You can, try to assimilate a lot of this information. But if you want to cover all of this efficiently, but also do lots of high challenge questions in depth, so you understand why this is the right answer, how to map all of these things, understand all the subdomains, that's exactly what our 2-day MSRA grammar course is for. So it's over 14 hours of teaching, a full day on the clinical on the 30th of November, a full day on the SJT on the 1st of December. We'll cover exam technique for each paper. For clinical, we'll go through over 100 clinical topics that are high yield. We'll cover all the key ethical guidance for the SJT. You'll do time teaching mocks, one each day. We'll review the current guidelines and relevant ethical guidance. We've had great feedback over the last 17 years. All the questions in the grammar course are unique. They're different to the ones that are in our question bank or available in any books or anything like that. So if you book the live session, which is 30th of November and 1st December, you'll also get access to the recording for a month afterwards. You can watch back all the videos as many times as you want for revision purposes. And it includes access to our question bank, with over 2,200 questions and mock exams up until the question bank. You'll have access until the end of February in case you get allocated the February exam. You can see again, we've had great feedback. This doctor got ophthalmology, 627. This doctor got 600. They got both offers for GP and CST. If you were to book all of these things separately, so day one, day two, the questions, all of that, it would cost you over £600. If you book the bundle, you essentially get the questions for free and you get access to the recording too. Okay, so this is what the recording looks like. These are all the different sessions on day one, all the different sessions on day two. And I think sometimes people think, okay, do I need the course? Not everyone needs the course. For some people, if you've already got really good knowledge base for the clinical, got a good understanding of SJTs, you've got a lot of NHS experience, you know how everything works, how to apply that GMC guidance, you're familiar with SJT question types, then, just doing questions and doing reading might be enough. I'll tell you 3 groups of people, perhaps, where the course might really help you. You're applying for a specialty that's ultra competitive, and within that, you only really can consider a few areas because maybe your partner's got a job or you've got kids in school. You can't consider anywhere. You're restricted. So even with something that's competitive, you're only going to consider a few areas. So you need the absolute best score possible. You don't want enough just to get an interview, because in most cases, it also carries over, right? You want to do everything extra, every little bit that can help. And that's one category of people. Number 2, you maybe have sat it before, and you might have a good score, but you've seen with the level of competition that is, even good scores aren't getting interviews or necessarily getting a job. And you just want to do whatever you can to change. And if you've sat it multiple times, and especially if you get stuck on the SJT and you're just not improving, that's often because you haven't understood the techniques. SJT is more technique than knowledge. And once you understand how to approach it, how to map to those domains, it suddenly clicks and you see huge difference. But this doctor, they were really worried because they found SJT is difficult. They ended up getting over 300 in the SJT. They were already strong with clinical. So, had they not done the course, they probably still would have done okay in clinical, right? But they ended up number 2 in the whole country in psychiatry, number 5 in the whole country in GP. They got the only run-through CAMS post in Maudsley, which is a, very popular job. And that's what they took, 618 total, okay? Here's someone, they got 552 1 year, not quite enough for anesthetics for them after once they got the interview to get the job. What I really like about this doctor, they didn't give up. Now, this is already a really good score. So they clearly had good preparation, good knowledge base, good basics, you see. But it made a difference because they went up from 552 to 625. And that was enough. They actually then ranked 6th after interview in the whole country. They got their first choice anesthetics rotation in London. Okay. This is someone that once they understood how the domains are tested and went through detailed explanation, it changed how they approach SJTs. They went from not getting a great score to the top band, 623, first choice. Okay. Again, for the SJT, particularly helpful in demystifying it. This is someone who increased by 70 marks. They actually got obstetrics and gynecology a couple of years ago. They had a good score, 540, very good. Okay. For different reasons, they had to leave O&G training. They decided they didn't want to carry on with it. They applied for GP, and they knew competition was going up, but they could only consider a specific area. They needed to stay where they were. By this stage, can you see you've already been in training for a couple of years? You might have bought a place, you might be established, your kids might be settled, and so on. So they did everything they could. They made a difference for them. 70 marks. Went from 540, which is very good. 610, though, this is like the top 1%, 2%. Okay. And then, many others. So let me just cover how to prepare, because I can see we've run over actually. And then I'll take any other questions. So some common reasons for not getting the score that you want, either a low score or, a good score, but too low to get the job that you want or to get an interview, and how to avoid them. Number 1 is not allowing enough time. I'd say there's 3 groups of doctors in terms of how they approach when they start MSRA. So there's people that find out the timeline and they know what their rota's like and how busy their life is, and they just plan ahead. And even before they've applied, they already start preparing. So they might know that, look, I'm busy, I've got childcare responsibilities, I've got on calls. I can't put in 3-4 hours every day, I've got to therefore allow more time. And they might start 6 months before and do an hour a day. And some days they know they've got a busy on call, they're not going to do anything. So they allow enough time. So they start early and they just consistently plug away, do lots of questions, do lots of reading, and allow time. Then you've got doctors that wait until they've applied, and then it starts becoming serious, and then they start their preparation. By that time, though, because of when applications close, they're only going to have a couple of months. Then you've got doctors that until they actually get an invitation to book, they're worried, will my application be longlisted or not? They don't start. The problem is, if that comes middle of December, if you get allocated the January exam, you might only have a few weeks. And remember, it's not about pass, fail. Nearly everyone passes. It's you're competing with thousands of other people that want that job. So the opposite of that, start early and be consistent. Do something every day, even if it's a little bit, okay? Underestimating the exam. I think a lot of people, they will talk to colleagues who maybe got in years ago. And a good example of this is a GP. Like 4 years ago, you could get into GP training with a score of low 400s. This coming around 500 might not even be enough. Okay, what is considered a good score has changed over time just because the competition is increasing. And so I think sometimes people, they talk to a colleague who said, oh, I did it in a few weeks, but they were applying in a very different environment because the competition hadn't doubled and tripled to where it is now when they were applying 5-6 years ago. So sometimes people underestimate also just the fact that it's not a pass-fail. It's competitively ranked. You can score well and not get a job. You can score well and not get an interview. And that how large the clinical curriculum especially is. Okay, so the opposite of that is to understand that the level of competition is significant. So, you need to put the hours in. Focusing on one paper, I've seen several doctors that get a brilliant score in clinical, but totally fail the SJT or get a really low score in the SJT. So their total score isn't high enough to get a job or to get an interview. Both papers are equally weighted for the initial ranking. And then lastly, poor exam technique. This is something actually, especially if someone has put hours in, they've often done multiple question banks, applied 2-3 years in a row, and they see very little increase in their scores. It does go up a little bit, but not as much as you'd expect for someone who's on their third attempt or something like that. Is that often, that's not that they've not done hard work. They've put the hours in. It's often exam technique that's let them down. So, learning the keywords, practicing time management, knowing how to approach different types of SJT. Once you master those things, then apply the hours as well. It can make a big difference because then every time you're practicing questions with a better approach. And then that goes through into the day. So then how to prepare effectively? Look, we've got lots of doctors over the years. We've helped to score 600 plus and even more 550 plus, competitive scores. And one of the things is if people do particularly well, I'll often either interview them or talk to them, ask them to share their tips so we can pass it on to others. And this is what I would say are the tips of those that score really well, that they will have an understanding that there's a benefit in both active and passive learning. So most people that have got really high scores will have done lots of questions, thousands. Generally, they will have done 2 question banks in full. So that we've got 2,200 in ours. If you added something like past medicine, that's another few thousand. Between the two of them, if you've done 4,500, 5,000 questions and completed them all at least once, just through exposure, especially for clinical, that can make a big difference. But then they also understand that there's a benefit in doing some reading. So they'll read up on the topics that they don't do well in. They make sure that they cover the curriculum systematically. So they know what's in the exam and they allow time to do the reading and practice questions on all of them. They're consistent. So once they start, they will have a timetable. They'll have some targets, 50 questions or 40 questions in a day, or, each weekday, I'll do at least 60 minutes. If I've got a bit more time, I might do 90 minutes, once I've got this run up to the exam. On the weekends, or if I get some time off, I'll try and do a little bit extra, okay? They'll practice realistic questions. So they're prepared for the right format when they get to the exam. They work on their exam technique because they understand that it's important. They do timed mock exams, so on the day, they don't run out of time. And then finding a specific single study partner or a very small group. What sometimes people do, which often doesn't work, and if you join a big WhatsApp group, there's hundreds of people, what often happens is lots of people give confusing things. You actually end up, it does more detriment than good. Whereas having one study partner, or maybe 2, so that you can say, look, today let's do cardiovascular 1. Let's say using our question bank, let's do cardiovascular 1 today. And then any that you get stuck on, you discuss it. But it's also, it's like, I don't know if any of you go to the gym. If you've got a gym buddy, if you've got someone like, if you think, oh, I'm going to go 3 times a week and oh, it's raining, oh, I'm a bit tired, you don't go. If you've got someone that you said, oh, we're gonna train together at 8 p.m., you feel like you're letting them down if you don't go, so you go. So having someone for that accountability, okay, have you done this set of 20 questions? Right, let's discuss the ones that we both got a bit stuck on. All right, have you done, just a reminder, that can be really, really helpful, but a small group, 2 or 3 max, not a huge group, okay? If you want to find some support, if you've got other questions, we have got a support group for any specialty that using the MSRA and one specifically for GP training. We'll post the links for that. As I mentioned, I'd recommend you do 2 question banks. So if you're going to do ours, add another one that will allow you to just get exposure to some different questions, particularly for the clinical, that will help. Then if you want that extra, and I mentioned that there's 3 groups. So we mentioned 1, people that maybe they're applying to a really competitive specialty or competitive areas or restricted areas for any specialty, okay? 2, maybe you're sitting not for the first time and you just, you want to improve your technique and actually just, you're happy even if I can add a little bit extra. You might have a good score already and you willing to, like if I had 20, 30 more, it might be the difference between not getting a job or getting my first choice versus my second choice, okay? The 3rd group is people that maybe for whatever reason haven't already started preparing and now might not have time to do everything on their own, read all these many guidelines and understand. And so you just want to maybe cover things efficiently. So, we've summarized the guidelines, we've summarized the ethical guidance, we show you how to apply it. It can just save you a lot of time. In those 14 hours of teaching, we'll be able to cover what on your own might take you several weeks to get through all the different places. We've put it all in one place. And you'll have the PDF booklet and you'll have the videos to watch afterwards, and then you've got the questions until the end of February to go with it. Okay, so you don't need any code. The discounts applied automatically if I show you. So when you go to the eMedica website, in the MSRA section, it's at the top there. So do you see it's automatically there. If you were to just book the clinical day, for example, that's $250. That doesn't include the question bank. You need to get that separately. If you just book the SJT day, that's $250. Whereas this includes both of those and the questions and the recording. Okay, now that's automatically applied. However, we do have some discounts available for, I mentioned earlier, this webinar is being run with the Medical Protection Society. If you're an MPS member, please check your email. They will have already sent you an email to tell you about this webinar. Within that, they include a discount code that will give you a further £25 discount off the already discounted price of the 2-day course. And similarly, if you're already using the eMedica question bank, remember this includes a question bank, but if you're already using it, then you can get a discount to account for the fact that you've already paid for the questions. Drop us an email, contact the team, and we'll help you with that, okay? And just, I'm going to summarize, but I just leave you with, just a reminder of that it can make a difference. We've got hundreds of testimonials. We've got thousands of people that we've helped over the years because we've been running this since the MSRA started, 618. They got their top offer. This person got their first choice radiology, and the course really made a difference for them. This person got international graduate, not only got ophthalmology, which is competitive, but got London Deanery, which was the most competitive deanery to get it in, okay? And again, they found it really helpful. And also on our blog, GP Training Support, and we've got a blog on the eMedica site as well, we've got interviews and articles written by people who have got fantastic scores. So Dr. French scored 627 in 2024. Dr. Makija scored 625 in 2024. Dr. Defala in an earlier year got 623, okay? These scores would be enough to get an interview for any specialty. And for those where it carries over and plays a weightage, these are in the top 1-2%. And there's just a few examples. So, do join the support group either for MSRA if you're doing any specialty apart from GP, or the GP training specific one if you're doing GP. Subscribe to our YouTube channel if you want to get access to the recording. And I leave you with this. Look, this is a 2-part assessment. They're both important, so please give time for both. Whether you get shortlisted or not, and then in most cases your rank will be impacted by the MSRA. Every mark matters. 1 mark could be the difference between getting the last interview slot and not, between getting your first choice job and your second choice job, or getting a job and not getting a job. Because just passing isn't going to be enough in almost every case now. So, focus on your revision, practice under time conditions, put in the hours, all right? And I leave you with these two messages. Michael Corder said, to succeed, we must first believe that we can. Don't think, oh, it's too competitive. I can't get this area or I can't get this specialty. You're a talented, intelligent person to get this far in your career. Someone is going to get that interview. Someone is going to get that job. Why can't it be you? To start with, I can do this. And I know it's going to be hard, so I'll put the hours in and I will do this. Because if you start with, I don't think I can, it becomes a self-fulfilling prophecy. Because now you're feeling a bit, oh, that was a tough shift today. I'm not going to make it anyway. I won't bother studying. There's no point. You give up hope. Whereas if you think I can do this because someone can do it, why can't I? Then even when you don't feel like it, you're going to study because you understand that if you're consistent, success will come. And then what Malcolm Shabazz said, that the future belongs to those who prepare for it today. Hopefully, I've dispelled some of the myths. There might be some things that you didn't realize about how this exam is structured or about the SJTs, for example. Now you've got a clear idea. Now it's up to you to continue that. This is the first step. Some of you hadn't started preparing until today. Well, we've done some questions together. At least you already kick-started it. Keep it going. Do something every day. Put the work in, then the future will belong to you. And come the results, I hope to get an email just to let you know I smashed it. I got my first choice job, or I got my interview in the specialty that I wanted. I'd love to add you to the list of those many other doctors that have come before. Okay. So for anyone that hasn't got questions, I hope you found it helpful. Thank you so much. I wish you every success with your preparation, with your exam, with your applications. All the best. Prepare and you will succeed. And our whole team and the MPS wish you every success. Okay. Just a reminder, we only will be picking up questions in the Q&A, and I will close the Q&A in 1 more minute. So if you've got a question, please ask it in the Q&A. So someone's asked, does the bundle come with access to the clinical case cards as well? No, the case cards are available for those applying to GP. We do have a bundle, our GPSD Pass Plus bundle, which includes like one-to-one coaching with me and case cards. That's specific to GP and includes the MSRA and our Getting into GP training course, which also covers how to complete the application step by step. But for this, it includes attendance at both live sessions, recording of the videos, so 14 hours worth of videos for a month, and then all of the questions and mocks up until the end of February. Okay, you can add to that the case cards, and if you book this, you can get the case cards at a discount. Drop us an email and we'll send you a code. Someone asked, can you apply for 2 different specialties? And in that case, will you have to sit the MSRA twice? Great question. You can apply to as many specialties as you want. You can just fill in a separate application on Oriel for each one. You might meet the eligibility for one specialty and not meet for another. So make sure you look at the person's specification. If you do, you only sit the MSRA once. And the same score will automatically be applied to any specialties that use MSRA in this round. The same score will give a completely different rank in different specialties. So for example, a score that might give you a rank of 5,000 in GP, that's 5,000 out of 12,000 people that are ranked, might be very different to the same score, might give you a completely different rank in psychiatry, where you're being ranked out of, say, 6,000, 7,000. And that same score might not be enough to even get an interview for some of the other specialties. Okay. But your score will be the same for all of them, because you only sit it once. Someone asked, will there be any content which is England specific? That's an excellent question. No. This exam is the same exam for all 4 home nations, England, Wales, Northern Ireland, Scotland. So anything where the answer would be different in England, for example, the age and how like the age range that they start doing bowel screening is different in Scotland than it is in England, Wales, and Northern Ireland. So that wouldn't come up. How often they screen people with cervical cancer or for cervical cancer is different in different parts of the UK, so that couldn't come up. But other aspects that are the same could come up, okay? Someone asked that they already started doing questions and they're worried because they're scoring 70%. How do you make it better? Well, for some topics, it might be that you're less familiar. So I would recommend you read up about a topic that you get wrong. Beyond reading the explanation, read up the relevant guideline so you have a richer, deeper understanding of it. And then beyond that, it might be technique. So that's where the course will really help you. Once you understand how to spot the keywords, how to sort of get to the right answer more quickly, that can make a big difference. Okay. Someone asked, can someone apply again while they're waiting to get an offer in the current round? Yes, and it will have no impact on your current round. Someone said, what other question bank would you recommend? It doesn't really matter. There's some people that will have found success with any question bank. So you could use Past Medicine, you could use MCQ Bank. I'd say they're probably the 2 others that most commonly I hear people have found helpful alongside ours. So either one of those would be fine as a second bank, past medicine or MCQ bank, I think. Someone said that the main problem is the SJT part. So if they said they're going to attend the course, if you attend the course, we'll cover it, and we'll also give you links for after the course where you can practice more questions and where you can read to get a better understanding of some of the things we've talked about. So we'll cover that, of course. Okay. Someone said, how can I correlate my performance in percentage to the actual marking in the real exam? If you're using the e-Medica questions, when you do a set of questions, at the end, it gives you an idea of what band would that place you in. What you're aiming for is band 4. Okay. Band 4 generally means you're scoring about 90% in each paper, and that's going to put you into band 4. Maybe slightly less is needed in clinical, but in SJT you need about 90% to get there. That's what you're aiming for. Now, I'm not saying that everyone will get that, because band 4 is like the top 8-9%. But if you aim for that, and then you're working towards that, rather than settling with, oh, I'm getting 80%, that's okay. In the old days, getting band 3 might have been enough for you to, get the job that you want. This year, loads of people that got band 3s got no offers at all for GP. And never mind other specialties that are more competitive to get an interview. So just keep working towards the best score possible. That's what I always recommend to everyone. Aim for 600 plus, rather than looking for what's the minimum that I will need to get into this specialty or to get an interview. Okay, hope that helps. Okay, great. So that's the last question. Thank you so much, everyone. I hope you found it helpful. If you've got any questions, you can always send me a message on Facebook. You can email us. Our email address is on the main eMedical website. Okay, and I hope to see some of you at the 2-day course, where especially if you found today helpful, where we did an hour and 10 minutes. Imagine what 14 hours could do. Okay, of teaching across the 2 days alongside the questions. Okay, so thank you so much, everyone.